Hi, I'm Oksana Shlobin, and I'm Medical Director of the Pulmonary Hypertension Program at Inova Fairfax Hospital. I am also an Associate Professor of Medicine at Georgetown University School of Medicine and UVA. Welcome to the program today. Our program is titled WHO Group 3, an Understudied and Unrecognized Condition. So, as I mentioned, we are going to speak about pulmonary hypertension complicating chronic lung diseases, or Group 3 pulmonary hypertension. What we will cover in this presentation is how frequently pulmonary hypertension complicates chronic lung diseases. We'll emphasize that it is a progressive entity with both diseases, chronic lung disease or parenchymal disease and pulmonary vascular disease, driving both outcomes and loss of functionality. We will talk about association of the diagnosis of Group 3 PH with loss of functional ability, impaired quality of life, greater oxygen requirements, and increased risk of mortality. We'll discuss etiology of this condition and talk about hemodynamic evaluation as well as evaluation by other diagnostic modalities. So let's talk about classification of pulmonary hypertension just very briefly. Chronic lung disease associated pulmonary hypertension belongs to Group 3. Many viewers know probably that there are 5 different groups of pulmonary hypertension. Group 1 is something we call PAH. Group 2 is pulmonary venous hypertension, so diastolic heart disease is the most frequent cause of that. Group 3 pulmonary hypertension encompasses parenchymal lung diseases, in addition to other causes of hypoxia and some developmental lung diseases as well. And this is where chronic lung diseases fall. Group 4 is pulmonary hypertension caused by chronic clots as well as vascular occlusions. And Group 5 pulmonary hypertension is something we call miscellaneous, and there are a number of conditions that can cause that. The most recent World Symposium on Pulmonary Hypertension, 6th World Symposium, redefined hemodynamic definition of pre-capillary pulmonary hypertension. The old definition used a cutoff value for mean pulmonary pressure of 25 millimeters of mercury, and the new definition is over 20 millimeters of mercury. Just like with the old definition, the absence of left side disease with pulmonary capillary wedge pressure less than 15 millimeters of mercury is still a part of the definition, and pulmonary vascular resistance has to be more or equal 3 Wood units. The same document defined pulmonary hypertension and chronic lung diseases, and the definition is on your screen. So again, mean pulmonary pressure is between 21 and 24 millimeters of mercury. You notice there's a little bit of discrepancy between this definition and the pre-capillary definition. Pulmonary vascular disease has to be more than 3 Wood units, or mean pulmonary pressure has to be between 25 and less than 35 millimeters of mercury. You would notice that if pulmonary vascular resistance is less than 3 units, even with elevation in pulmonary pressures, that actually does not qualify someone for a definition of for presence of pulmonary hypertension. There is also a definition of severe pulmonary hypertension in the setting of chronic lung diseases, and that is defined with the presence of severe elevation of pulmonary pressures, so mean pulmonary pressure above 35 millimeters of mercury, or less severe elevation, so mean pulmonary pressure over 25 millimeters of mercury, but with presence of low cardiac index, so cardiac index less than 2. So let's talk quickly about prevalence of interstitial lung disease, just to sort of set a basis to understand how frequently we may encounter these patients in our clinical practice. Interstitial lung disease is actually quite common, and the prevalence is listed on the slide. It's about 81 per 100,000 men and about 67 per 100,000 women, so a little bit more frequent in males, with the idiopathic pulmonary fibrosis being the most common of the interstitial lung diseases. Precise prevalence of pulmonary hypertension in interstitial lung diseases is actually quite difficult to establish. There have been a number of studies trying to investigate this specific topic. However, the modalities for diagnosis are highly divergent. So there were studies that used echocardiograms, diffusion capacity, and there are actually very few studies that use right heart catheterization, so true hemodynamic definition of pulmonary hypertension. So it really is still unknown. And obviously, with the most recent change in the mean pulmonary pressure cutoff from 25 down to 20, that data is also not yet known. We do know from a number of the therapeutic studies in idiopathic pulmonary fibrosis that in early IPF specifically, somewhere between 5 to 15% of patients have pulmonary hypertension. So this graph comes from a study that our group did, which was published at this point about 12 years ago. And it looked at IPF patients that were referred to our program for possibility of lung transplant or lung transplant workup. And there is a little bit of bias in this patient population because presence of pulmonary hypertension is actually one of the reasons to refer a patient with IPF for lung transplant workup. Having said that, on the left side of the screen, you'll see that about 38% of patients who were referred for workup and who were undergoing workup had presence of pulmonary hypertension. We followed those patients and repeated the heart catheterization at the time of their transplant, and at that time, 87% of patients had pulmonary hypertension. So what this implies as people go towards transplant and their disease progresses, they're much more likely to have pulmonary hypertension. If we switch over to COPD, there are some similarities and there are some differences in comparison to interstitial lung diseases. Pulmonary hypertension in COPD is also not very well studied for the same reasons as the interstitial lung diseases. But we do know is that pulmonary hypertension is a bit more common in COPD than it is in interstitial lung diseases. The severity of pulmonary hypertension, however, is usually very mild, and several studies show that only about 5% of patients with COPD have severe pulmonary hypertension, as defined by that cutoff of 35 millimeters of mercury. There were several studies looking at exercise hemodynamics in patients who have COPD-related pulmonary hypertension, and they did show that there is very rapid rise in mean pulmonary pressure, probably indicating loss of lung vasculature and vascular distensibility, as well as vessel recruitment capability. Both studies did emphasize that one has to be very careful to rule out left-sided heart disease in COPD and in interstitial lung disease, especially when patients are older. They are likely to have comorbidities, and diastolic dysfunction is one of them. So this is something that right heart catheterization can help us figure out either with exercise testing or volume loading. There is some specific genetic signatures that have been linked to COPD pulmonary hypertension, and there is this pulmonary vascular COPD phenotype that has been described that indicates that the patients who have less severe airflow obstruction, who have hypoxemia, especially exertional hypoxemia, very low diffusion capacity, absence of hypercapnia, so not normocapnia or hypocapnia, and cardiovascular exercise limitation profile on exercise testing are likely to have pulmonary hypertension related to COPD. This slide demonstrates what I mentioned just a minute ago about the distribution of mean pulmonary pressures in patients with COPD-related pulmonary hypertension. And as you can see, most patients really have very mild disease hemodynamically, and a few patients have severe disease. This was a recent paper published in Chest just last year that looked at some histopathology specimens in patients who had pulmonary hypertension related to COPD or in the setting of COPD. And if you just focus your attention on the bottom slides, you will see that the vessels in those histograms look very much like vessels in a patient with idiopathic pulmonary arterial hypertension. So that really underscores the notion that these patients have a true vasculopathy, and it really is driving their hemodynamic and probably clinical picture. This slide is meant to summarize all of the different reasons why patients with chronic lung diseases, both COPD and interstitial lung diseases, may develop pulmonary hypertension. This, if you focus your attention on the left side of the slide, in the yellow portion of it, under a vascular-centric pathway, we do know that there are some cytokine derangements in patients who have chronic lung diseases and concomitant pulmonary hypertension that are similar to what we see in patients with group 1 PAH. Several studies looking specifically at interstitial lung diseases have described in situ thrombosis as well as increased risk in patients, let's say with IPF specifically, for both acute and chronic pulmonary emboli. In the center of the slide, there is a parenchymal pathway that summarizes all of the ways that can contribute to development of pulmonary hypertension. So obviously the first and the most important one would be capillary bed destruction and ablation of vasculature. Neovascularization or formation of new vessels would go along with that. Anytime when there is a destruction of vasculature and capillary beds, there is ventilation perfusion mismatch that happens on a local level, which causes hypoxic vasoconstriction. And we know that hypoxia can cause vasoconstriction, thus elevating pressures even further. Patients with interstitial lung diseases, specifically with idiopathic pulmonary fibrosis, have been described to have lesions consistent with PVOD. There are also description of periadventitial fibrosis in patients with interstitial lung disease, and that can cause decreased vascular capacitance. The data on COPD is similar to interstitial lung disease, just not as abundant, but also points to very similar processes. Now, if you go to the blue part of the slide, under comorbidities, there are several processes that are highlighted there that I would like to emphasize. One of them is obstructive sleep apnea. So obstructive sleep apnea is very common in patients with interstitial lung diseases and also more common in patients with COPD in comparison to general population. And if untreated, it definitely can cause hypoxemia at night and can drive elevation of pulmonary vascular pressures, or pulmonary pressures. Diastolic dysfunction is also quite common. I already alluded to that in the previous slide, and really needs to be elucidated when performing right heart catheterization and looking at the echocardiograms. And coronary disease is quite common as well. Very often these patients present with increased shortness of breath. They have limited exercise capacity, and it is not uncommon for them not to have chest pain. So you really have to be looking for coronary disease and actively trying to exclude it.